Okay, so what I'm going to do is take you through this as quickly as I can. Some of you have already had this orientation and some of you have not. So for those of you who haven't, this will probably be helpful, and it may remind some of you of who have had it of a few things that we need to make sure that we cover in our scenarios. The purpose of all this is to bring consistency throughout our entire program. Our education is based on the EMS education standards, which now are a living, breathing document that changes with medicine. As medicine changes, then we're easily able to make those adaptations. The American Heart Association, the Pre-Hospital Trauma Life Support, Basic Trauma, International Trauma Life Support, PALS, all of the pediatric courses, those are really the organizations that set our standard now. And as those standards change, then we'll be able to adapt with these scenarios and maintain that level of consistency that we need for our students. Our goal is to graduate entry-level paramedics. And that's something that it's important to keep in mind, is that these students are just learning the entry-level education standards to function in this profession. So as we grade them, as we help them, we have to make sure that our expectations are not any higher than an entry level for the graduate. Every lab, with the exception of specific skills labs, are centered around scenarios. And what I mean by that is when we're teaching cardiology, all of the labs will be built around scenarios that cover the specific objectives of what we're trying to teach the students that particular day. An example of a skills lab that's not going to be scenario based would be like your IV therapy lab. That's a lab where students are coming in and they're simply trying to get that muscle memory, learning how to stick the needle and how to thread the catheter and how to bleed the air out of the lines and things like that. You know, given medications, they're learning how to draw up dosages and stuff like that. Not so much a scenario format for those, but any other topic just about in our whole course is going to be covered in the labs through some sort of scenario. They are specific, objective-based scenarios. They're going to cover the material in that lab will be objectives that were taught recently, either the day before or the week before on that particular topic. An example, if we cover endocrine emergencies and we cover diabetes, and we cover hyperglycemia and hypoglycemia today in class, then tomorrow's lab will be built around that specific information on hyperglycemia and hypoglycemia. That way they get the lecture, they learn the initial didactic material in the lecture format in class, and the next day they come to lab and they learn to apply it. They learn to assess the patient and use their critical thinking skills and apply the knowledge they learned yesterday in a real life scenario today. The respiratory and neurological emergencies in class might be covered the last week, and then this week we have 2 labs that cover those specific topics. Usually, in most circumstances, I will teach the information to the class one day, and the very next day or after the weekend on the Monday is when that material will be covered in the labs. The purpose, to challenge the students to higher level critical thinking skills. All of the recommendations coming out of your National Association of EMS Educators is promoting and pushing critical thinking skills, and really the only way to do that is to put the students in as lifelike a situation as possible. Now, the fast track paramedic, the accelerated paramedic is the class that I teach. But we are using these scenarios in the regular 12-month program as well. Now the fast track paramedic is extremely fast paced. We cover a massive amount of material in a short period of time. So one of the things that we ask the instructors to do is please avoid teaching your own opinions and protocols. What we need you to teach is the assigned scenario for that day. When you have as many people coming in from different organizations that have different protocols that they base their patient care on, they'll come in and instead of teaching the universal care of a patient with a specific complaint, they tend to want to teach what's in their protocol at their service. That may be different. It may be a different medication, a different therapy for the next service down the road 25 miles. And if we have different instructors coming in from different services, if you teach your protocol, the students may literally miss the bigger picture of just using a class of a certain type of drugs rather than a specific drug. Some examples that I've seen in the past are a push dose pressor. An example of a push dose pressor would be a vasopressor like dopamine. And we give dopamine for cardiogenic shock. We give it for vasogenic shock, distributive shock, where we want to constrict somebody's blood vessels and bring somebody's blood pressure up. And there's different methods that dopamine can be given. It can be given as a push dose out of a syringe, which some services are doing nowadays. It can also be given as an IV drip. So in our scenario, the most common way that it's given is a dopamine drip. And so that's what will be written in the scenario as the treatment therapy. Since fewer services are using it as a push dose pressor and it's actually not in the textbooks yet, then right now we wouldn't want somebody that uses it that way to come up here and teach it that way, because that's not what's going to be on the National Registry exam. So I've had paramedics come up and teach that lithium is given for schizophrenia, and that's bad information. Lithium is given for bipolar disease, and you all know that, but the one person got confused one day and taught all day long that lithium was a drug that was used for schizophrenia, and that was bad information. So at the end of the day, we have to go back and fix that. And these scenarios are designed to keep instructors from those common errors that can be made like that. It will be specifically written. I'll actually share one with you in just a little bit and show you exactly how it works. So the goal of the scenario is to make the scenario as realistic as possible within the allotted time frame. We want to run a scenario in about 10 to 15 minutes. A few things are sped up, like transport times. There's no need to literally move the patient to the mock ambulance. Our scenarios run like you'll come into a setting and you'll work your way through a scenario on scene. And then once you get the patient moved to the stretcher, then we probably tell you at that point, okay, you're in the ambulance, tell us what you're doing on the way to the hospital. And that way we don't have to sit through the whole 20 or 30 minutes of transport time just for reassessment purposes of our patients. If you want to create a change, this is important, if you want to create a change in the condition during transport, that's fine, but make sure you don't lead the patients, lead the students into a completely different scenario. An example would be, we don't want you to start out a patient as having chest pain, like they're having a heart attack, and then halfway through the call make that patient have a seizure. The purpose of the scenario for chest pain today is about working cardiac patients. So we want you to keep the patient in the chest pain cardiac scenario. If you want to make them get sick at their stomach, vomit, if you want to make them tell you, hey, I feel like I'm going to pass out, things like that are fine as long as it's related to the cardiac event that's happening there. If you take them down the road and lead them into a cardiac patient that now has a seizure, and now they're having to treat the seizure, you've created a whole new scenario for that student. And they may not have, at that point, ever been taught anything about seizures just yet. So we want to make sure that you stay within the seizure, within the scenario. We want to make sure you stay within the specific scenario that you started out in and finish that one. That way it makes sure that you cover the learning objective that you were supposed to. It's a team-based approach. You have to have a patient. It can be a mannequin. It can be one of the other students in the class can play the role as the patient. You yourself, the instructor, can play the role yourself so long as you still have controls and everything of all of your equipment that you're going to use. We're going to use all of our appropriate equipment for the scenario to make it as lifelike as possible. Example, I simulate EKG rhythm generators. We're going to make them use as much technology as possible, just like it's a real life call. We'll make them put the SpO2 on the patient. We'll make them put the EKG on the patient. We'll make them use end-tidal CO2. And all of our equipment is able to give them immediate feedback on what those things are once they hook that equipment up. So don't just tell them what it is. If they ask for SpO2, for instance, if they haven't put the SpO2 monitor on the patient, then you tell them, well, you haven't put it on there yet. You got to put on your finger probe to find out what that is. If they ask for end-tidal CO2, they should, if they've put that on, they can look at the monitor and see what it is. If they asked you what it is, then obviously they haven't hooked it up yet. So you simply tell them, hey, if you want to know what the end-tidal CO2 is, you got to hook it up to the patient first. So you know, sometimes until they get in the groove of things, the more of these that they do, the better and more efficient they become at it. The partners get to where they're doing this stuff for their team leader. The team leader is getting to where he is, if he notices something's not being done, he tells his partners to do it. So these students are learning to become team leaders as well as team members at the same time. So each team usually consists of one team leader, and you can have one partner what is on an actual EMS unit, or you can have two partners to allow other students, more students to participate more and get more experience. They should rotate their roles as the day progresses. The team leader runs a call this time, and the next time he's up here, he should be a team member and somebody else should be in the role of team leader. At some point, there should be an instructor confirmed evaluation. The team leader is evaluated as the team leader. If we can, we want to give feedback and evaluate the team members as they played their role as well. So mistakes and errors can be corrected as the scenario progresses early in the program. And by that I mean, if today's our first day to really start working with patients in labs, and they're supposed to be live patients, and we have these scenarios we're going to cover, they're going to be kind of rough. The students are not going to have that muscle memory and assessment process down as well. So early in the program, when you're doing a lab-based scenario, if they're messing up in the beginning, if they forget to establish someone's level of consciousness, for instance, stop them right then and say, okay, now before you progress to the next step, what's something that you haven't assessed yet? Prompt them. It's okay to help them. If they can't think of it, say, okay, now wait a minute, I haven't heard you really assess the level of consciousness yet. It's okay to remind them and prompt them. They're going to do so many of these throughout the year that they're going to get by the end of the program, you're really not having to prompt them to do anything because they do this over and over and over. And by repetition is how they learn it. So the program should be more aggressively, the scenario should be more aggressively critiqued toward the end of the program. That's where we're letting them leave things out, and at the end of the scenario we remind them of it, or we ask them questions that then prompts them and they realize they've forgotten it. And so the grading at the end on how well they do on a scenario is actually done a little bit more thoroughly at the end of the program. At the end of the scenario, 10 to 15 minutes to critique it. Tell them what they did wrong, what they did right. Remember, the critique should be a positive experience, even though you're going to have to tell them some negative stuff that they might have left out or forgotten. Overall, they still should feel pretty good about what they've learned and how they can improve. I've got a note here on the PowerPoint there that you can tell probably what that cluster means there. I've actually had instructors come in and say, after students really mess up on a scenario, he'll say, well, that was a cluster blank. That's not a positive experience for the students. So we want to avoid stuff like that. Quickly answer their questions, try to avoid lengthy conversations. Remember, I've already taught this material, or Dean has already taught this material to his students. What we're doing in the lab is trying to refine that knowledge. So you don't have to re-lecture. If you just did a hyperglycemia call, you don't have to do a whole lecture on hyperglycemia. They already know the basics of it. You need to kind of direct them and tell them how they did on the assessment and treatment of the patient, how they can improve doing that, what things that they might have left out, or how they can do better. Make it an overall positive experience, constructive criticism. It should not be a beat down if possible at all. Okay, so the next section, I want to take just a few minutes and look at a couple of different scenarios to make sure I clarify, how these things are supposed to run. So the first one that I have up on the board here is a stable SVT. And I'll try to keep this brief because you can see the goal of it here. But what you'll do is you'll have a patient, somebody playing the role of the patient, either one of your students, our mannequin up there, and you can even use your own voice and voice through the mannequin and make it almost like a live patient. Or you can just answer the questions yourself without actually being voiced through the mannequin. But they'll respond to a call, and the way it starts, it says you respond to a 63-year-old female patient complaining of dizziness and heart feels like it's skipping beats. So the students enter the room with all of their equipment, just like they would on a real call. Their kits should be fully stocked. Anything they need, they should be able to get it out of that kit and use it on the patient. If they end up having to give a medication, they should have that medication in their bag. They should pull that medication out, actually draw it up, and simulate pushing it into the patient so that they go through those repetitive steps of actually giving correct dosages and the process of giving meds correctly and things like that. So whatever they have to do, as much as you can, make them do that skill while they're doing the scenario. So they do a scene size up, they make sure it's safe. They come in, they go through their primary survey, and y'all understand all the process here, so I'm not going to explain each one of these, but in this particular patient, they're alert and oriented, no acute distress. Their skin looks good, their pulse is good and strong. It's just their pulse is really fast. So throughout their history, it says they start asking the patient questions, and once they start talking to the patient, then the team members should be doing their jobs. They should be hooking the patient up to the EKG. They should be putting them on SpO2. They should be hooking up end-tidal CO2, starting an IV, getting a set of vitals. If they're doing their parts, that's great. The team leader can just talk to the patient and do assessments. But the team leader is responsible if he notices his team members not doing that job. He needs to call their attention to it while he's ultimately responsible. So while he's doing his assessment, he also has to make sure that they are doing their job as well. So on this particular call, there's nothing significant. The patient says, my chest feels funny, I'm a little dizzy. I was driving home, started feeling this way, and pulled in and asked the store owner to call 911. Started about 30 minutes ago, and they go through all of their OPQRST questions and get that information, and they get the information pertaining to the sample. And then by this time, everything should be hooked up, SpO2, end-tidal CO2, EKG, so they can look at the patient's monitor. And all of that information is right in this area right here on the secondary assessment. You can see that the patient's, there's no JVD, trachea's midline, breath sounds are present and clear. As they do their assessment, you'll either have the mannequin set up to have these specific things they'll find, or you will tell them what the information is as they do their assessment. Either way is fine. I like them to physically do the assessment if they can. That's why I like using the mannequin, because it can give you breath sounds, things like that are realistic. It can give you a real set of vital signs. So here's the vital signs, and then I've got the SpO2 there. That's what should be showing on the monitor. The cardiac monitor should be showing SVT in this case at 170 to 180. And if they vocalized getting a blood glucose level in it, you'll tell them it was 126. And then we've got what they're supposed to do based on this information on this particular patient. This is a stable SVT patient. And this is the information right here that you will teach as treatment for that patient. You're going to teach this treatment for this scenario, and 2 months from now, a different instructor will come up here and use this scenario, and they will teach the very same thing. This is the area that we don't want you to deviate from it, because this is the generic treatment for that specific type of patient. It covers all protocols. And for this one, you can see it says a O2 IV, attempt vagal maneuvers, adenosine 6 milligrams rapid IV push, followed with a 20 milliliter saline flush. And then it says what the second dose can be. And then it says consider one of the following if that doesn't work. And pay attention to what it says here, because they can give calcium channel blockers like diltiazem or verapamil, and you'll notice the word or there, or they can give beta blocker. That word or there is very important. They should not give 2 of those meds. They're going to pick, and they can pick any of those 4 and give it, and it's correct. So if they pick one of those 4 and say that's the one I would give, then that's correct. Some of them may list all of them off to you and say I would do this or this or this or this, and that's fine as well. They're just demonstrating that they know that material very well. So comparing that scenario to the next scenario, this is an unstable SVT. Oh, and by the way, a lot of these, especially cardiac scenarios, we put the EKG rhythm on there. So if they ask for a 12 lead, you can actually hand them this piece of paper, and there's their 12 lead that they can look at for that patient. Now, the difference in this patient and the previous one is this one's complaining of chest pain and severe weakness. They are ashen in color. They look pretty ill. They're alert, but they're having, they're pale and sweaty. They're having this significant chest pain. And as they go through here, based on very weak and chest pain, and the fact that this patient's blood pressure is 82/48, this patient will be unstable SVT. And of course, there's a different treatment for unstable SVT compared to stable SVT. So there's your treatment written right there, specific to this patient. Again, instructor number 1 today is here teaching this. 3 months from now, instructor number 15 can come in, and he'll be teaching the very same material to these students. Okay, so the last scenario, and I know I'm getting long-winded here, but the last scenario that I have, I'll try to get through as quickly as an example, is hyperglycemia. This patient has a high blood sugar, and they have developed diabetic ketoacidosis. It's a 50-year-old male with a decreased LOC, and that's how the call comes in. So they come into this setting, whatever. In this particular case, it's an apartment complex. They enter the room, they go through their scene size up, they do their primary assessment, And on this patient has a decreased level of consciousness, and so they're unresponsive and they have snoring for their airway. When they assess the airway, they notice the patient snoring. So right there, by snoring, they should manually open that patient's airway to fix the snoring right then. Remember, in the primary survey, they have to fix it as they find it. And so they would want to do that action at that particular time. They would assess the ventilations. Once they get the airway is open, then they're breathing 28 and deep. They've got good enough respirations, and they'll check the circulation. This patient is unresponsive. So while the team leader does a rapid head-to-toe on the patient, he'll probably do that first and then get the information from the family. The family says they checked in on this patient this AM, but has not answered his phone because he did not answer his phone in a few days. So they went and checked on him. They found him 10 minutes ago, and there's his past medical history. The paramedic leader should ask all of those appropriate questions. He takes insulin. And then you can see the physical exam that they find here on this patient. He's got a fruity odor to his breath. He has clear breath sounds, but he is so dehydrated that his blood pressure is 70/50. Pulse is 120, respirations are 28 and labored. O2 sat is 86, so they should be putting this patient on O2 if they haven't already. It's got all the entitled CO2 information there, the cardiac monitor information there, and then when they do the blood glucose level, they'll see that the reading says very high. So again, the treatment for this one is written out right there. That's the good thing about these scenarios, is this even relieves you of having to study and review this material. When you come up here to teach, all you have to do is be given these scenarios that morning, and you already know what you're going to be teaching. You don't have to review or study or anything because the information that you're going to be covering in the scenario is written out for you. For this particular patient, they'll open his airway, put in an NP airway, put him on O2, and then they'll start an IV of normal saline or lactated ringers and give him a fluid bolus until his blood pressure comes back up. So that's kind of the way they work. Again, the purpose of this is not to keep you from just coming up here and being able to teach. We want you to teach. We want you to share your past experiences with different patients. But at the same time, we want everyone here to remain consistent in exactly what we teach. So if you have any questions about this, I'm always here. Sherry is always here. Dean is always here. So if you have any problems in these labs, any questions at all, please come and get one of us to answer that question if you don't know the information yourself or you're not sure what you need to be giving them. Remember to stay within the confines of these specific scenarios as best you can. Don't take them into a completely different scenario by suddenly turning a diabetic patient scenario into a trauma scenario. We kind of can do that later in the year toward graduation. We can start mixing them up. But remember, they're really trying to refine what they learned yesterday in the classroom. So again, I appreciate everything you do for our students. We wouldn't be able to conduct these labs without you. So please let us know if you have any questions.